My next guest is Alessandra, who I've known for many years. I've seen not only her as a patient, but many of her family members, including her husband, her kids. I'm going to be talking to her about two kids that she adopted after the mother committed suicide, and then they ended up getting custody of these kids, who started with a very difficult background of fetal alcohol syndrome, and had a lot of behavioral problems dealing with bipolar disorder. So, and the transformation of these kids was pretty remarkable. So I hope you enjoy my discussion with her about this. So, hello, Alessandra. How are you?
Fine, doctor. How are you?
Good. So, how do you like the move from back east to Oregon?
Oh, love it.
Yeah.
I love the West Coast.
Yeah.
Closer to my kids, better weather, all kinds of.
So, you're not going to miss Massachusetts, huh?
No.
Yep. Well, I know that you have all your family out here, so.
Yeah.
Yeah. So.
Yeah, and actually, our youngest is moving to Portland in 10 days with his family.
Who is?
I'll have grandkids around.
Who is Sean? Sean is?
Sean.
Oh, nice.
Yeah,
how about John? Are you guys gonna get John? Are you gonna get John up there or no?
Probably just to visit. I don't think he's moving yet.
Yeah. Well, I did share with the audience that I've been seeing, Lexi, you and your family for how many family members do I see of yours? Quite a bit.
Thank you. Well, over the years, you've seen everybody, and we've been married 20 years, so
wow.
I think it's been that long.
Yeah. So share with us, what transpired for you, because I know you have two adopted kids. I mean, what's tough in your case is you've already raised kids. You were done raising kids. You thought you were done. You thought you were free, and then you get two kids you adopt. So if you can share the circumstance of what happened then.
Yeah. So their mom passed away in 2014, and
how did she die?
Sorry. Go ahead.
How did she die? What happened?
She overdosed. And the biological father was in prison at the time. So she, a few months before, she had asked us, myself and my husband, if something ever happened to her, would we take the 4 kids? So after thinking about it and, talking, we said, sure, we will. Unbeknownst to us, it was only a few months later that she died. So that was very unfortunate. So we were actually empty nesters for about 5 months, loved it. And then, and then we started all over. The kids were 5, 7, 9, and 11. All of them with ADHD, and 2 of them in particular, the older ones, with some PTSD from the abusive,
the abuse growing up.
Yeah. So we now are down to 2, a 14-year-old and a 16-year-old. And so they've been with us for almost 10 years. And every day is an adventure. We're so grateful for Dr. Corona and all his magic. I don't think at our age we would have survived otherwise.
Well, you and your husband are such just amazing people to do what you've done. It's really,
Like I said, you helped a lot.
So when I started seeing them a couple years ago, and I know they had the ADHD history, I started giving them ADHD, or I think the doctor, I think in Massachusetts, started them on ADHD meds. And how did they do on that? And what was the positive and negative of being on the ADD meds?
Yes. So the 16-year-old, since he came to us, we knew there were some deficiencies, and he was actually diagnosed with fetal alcohol syndrome.
Oh,
and
wow.
yeah, and ADHD and sensory processing disorder. So his frontal lobe is not completely developed, but the ADHD apparently is a result of the FAS and all that. The girl that's still with us, who's 14, she has ADHD, but not the FAS. So we're grateful for that. So in the last, I thought you started seeing them a little bit before that, but anyways, we, with puberty coming on and, the many things that children from hard places carry with them possibly throughout their lives, but certainly, increased with the hormones going crazy. We really needed some help with behavior, and also because at school they just didn't, they weren't able to not just perform minimally, but just be there.
Right.
So so that's what you suggested. I think the boy that we have, I think you started him on antidepressants first, and he's been the hard one to find the right mixture of things because, I think if there is a spectrum, he's definitely high on the spectrum.
Yeah.
And so, and it's not easy to really get a sense of where these children, what they feel, because they have very limited vocabulary and very limited, they don't know how to share their feelings. So it's hard to, put on meds and then understand what the medication is doing to them.
Right. I think he was put on Zoloft, if I remember right, and I think it helped him a little bit.
Yeah, I think
the other doctor put him on that.
Yeah. He's now on Effexor and Wellbutrin, and then you added the
Abilify.
The Abilify and the what is it called? The Vyvanse. Sorry,
right.
There's so many of them.
Right.
So a few days ago, so I administered the medicine because we thought we could let them do it at their age, but they forget part of the ADHD. So I went back to administering the meds morning and evening. And now I know that I have to watch them swallow it. It's not enough to put it in their hands. So a few days ago, the boy had a really huge meltdown because he didn't take him. He had him in his hand and then he went to bed. And so that was a hard day, very hard. So we know for a fact firsthand that it makes a huge difference when their brain is somewhat, stable and with the right chemistry. So now I have to watch them swallow them.
And what is she on again? And what is she on? The Vyvanse.
On guanfacine was a huge turning point for her, not for the boy, but for the girl. And then she takes also the Vyvanse in the morning, and that's really. And the Abilify.
Right.
Yeah.
So I think
the guanfacine was huge. It was a huge turnaround for her. We tried with the boy, but it really didn't do anything for him.
The huge for both of them was the Abilify. I think that's the last step I added on for both of them. And actually, you also did a really good job adjusting with the Vyvanse and the Abilify. We were trying to get that right mix between the two, so we had to kind of go up to a higher dose of Abilify with both of them. To get the results, because you have to counterbalance the ADD medication and with him the Prosteq Wellbutrin. So, I think Abilify probably made your lives a lot easier.
Yeah.
But it just shows that even non-compliance for one day, because the medications are only there for one day and then they're gone. So if you don't take it for one day, it makes a big difference. And people might say, well, what am I addicted to it? I can't take it. Well, no, that's not addiction. It just stops working. It's like, you don't tell a diabetic, oh, you're addicted to your insulin because you stopped it one day and your blood sugar. Right. No, that's just because it doesn't work if you don't take it. So case in point, like I said, it's just, you're right. Watch them swallow it, look inside, have them lick their tongue.
Unfortunately, we try to give them every year a little bit more responsibility, but then we forget. I think when you have someone who's handicapped and maybe bound to a wheelchair, the deficiency is very much in your face and you can't forget about it. But kids who look fine, they look healthy and everything. And so you forget, or I forget sometimes, that we have to have these meds, and the chemistry of the brain just needs these chemicals to help them function. So.
Right. Good. Excellent. Good. Well, I think they're gonna. Well, I mean, this is gonna make a difference in the rest of our lives, really. So moving forward, and if they had not gotten treated, it would not be a good situation. The kids like them that aren't treated get into lots of problems and a lot of behavioral problems. And then they get into crime, and they get into drugs, and of course, and it just is a bad way to go. End up in prison, end up like their dad. And the thing is with them, bad genetics. Their mom overdosed, whether it was suicide. I don't know if we knew that, but I mean,
on the death certificate, it does say suicide.
Right.
We don't know, and it is what it is. So, but there's definitely addiction in the family and genetically. We don't see it with them with alcohol, but we certainly see it with other things like video games.
Right.
They have an addictive personality. Them. So, the other thing I wanted to say was that about a year ago, when we lived on the East Coast, the pediatrician suggested that we go see, because of course you're in California, we were on the other coast, and so she suggested we go see a local doctor, a psychiatrist, who apparently was very well thought of and so forth. Anyway, the new psychiatrist changed the medication, and not 2 weeks later, our boy was arrested for a misdemeanor. So I was like, no, we're going back to Dr. Corona. We are not doing this.
Yeah. Well, you're almost, they're 16, 14, so, in a few years, you're going to be back to empty nesters, hopefully, and...
Yeah, well, we'll see. Hopefully we can make it 4 more years.
Yeah.
We're hoping.
And hopefully by that point, they're going to maybe become more independent, and so because you and Glenn have, you guys you deserve to get your life back again,
We're not quite done yet, but having the grandkids move close to us is huge. I'm so thankful for that. Yeah. It's been a long time since we lived close to them. So they're 3, the twins are 3 now, so they're awesome.
Well, God bless you for doing what you've done.
Oh, of course. And thank you, Dr. Corona. What is it? Glenn calls it, Dr. Corona does his magic.
I love doing it. I love doing it because I love seeing results like this. Like with kids like yours, who are so bad when they start off, and then when you get them better, it's just so satisfying to see that, because when you change one life, like you change the whole family dynamics. Everyone's life improves, really. So that's why I keep doing it.
You've been a godsend for sure.
Thank you. Thanks for coming on. Appreciate it.
Of course.
Okay. Talk to you soon. Say hi to the rest of the family, by the way.
I will.
Okay.
You too.
Bye.
Bye-bye.
So anyway, if we let's go to the board here now. Just a trigger warning: I'm not an artist, so these drawings are very primitive. But I actually go through these. I give any new patient who comes to my office, I draw these out because I love to explain what I'm doing. And by the time the person's leaving, they're understanding why I'm giving them which medication and what it's doing. So we break down the nervous system It's composed of neurons, which are nerve cells. And so under a microscope, a very high power microscope, a nerve cell kind of looks like this, what we call a neuron. And what's happening is the chemicals are traveling from one cell to the next cell around the body about 1,000 times a second. There's over 100 billion of these neurons, these cells in the human body. There's a space in between, we call the synapse. There's over 100 trillion of those in your body. So that's pretty mind-blowing, isn't it? Pun is intended, by the way. So it's so there's a lot going on. Each cell is connecting to about 1,000 to 10,000 other cells. So this is just a very simple drawing to try to keep things real simple. But it's a constant weaving network of activity that's going on in the nervous system. That includes not only the brain, that's the whole, this nervous system goes everywhere, down the spine, to your fingers and toes, your arms and legs, your stomach, everywhere. The nervous system's everywhere, which is also why we see differences like muscle tension and pain when the nervous system's out of balance. So I also break it down to neurochemicals. So I break it down to 4 key chemicals. There's other things going on. This is just, again, a very simple drawing. I wrote them here: serotonin, norepinephrine, dopamine, and GABA. And GABA or glutamate. So they have like a little receptor site, a little hole that they are traveling from one cell to the next, and they're supposed to be moving in a one-way direction at all times. And that's what's supposed to happen. Like I was telling in my story earlier, when I first started practice, what we had available were SSRIs. Like we had Prozac, Zoloft, and Paxil. So that stands for selective serotonin reuptake inhibitor. So it's telling you what it's doing. It's inhibiting the reuptake of serotonin. So what happens then is if the serotonin side is leaking, this side is opened up, and the serotonin is now going the wrong way and not just the right way, that's the problem. So SSRI binds to that serotonin site and stops the leak, and then forces that chemical to connect to the next cell. So it forces that normal flow. But what happened in 1993 when Effexor came out was the first serotonin and norepinephrine reuptake inhibitor. That was very key. And so when I started to see that not only serotonin, but also norepinephrine, and now you got 2 chemicals that are going the right way, not just the one. And then I started to really see a big difference as far as people, anxiety better, depression better. And what really struck me was the body: neck, shoulders, back, stomach, chest, head, fibromyalgia, irritable bowel. So all these things started getting better, and it was shocking to me because I thought, well, it's got to be the norepinephrine. That's the difference with this versus the SSRIs, and that's kind of started my journey in the 1990s, and what got me fascinated. So I started really looking at my patients and started to reevaluate everything I was seeing and say, so when people come in with pain, what do most doctors do? They'll give you pain pills, they'll give you whatever, they give you something for symptoms. Well, I started to see like, hey, I want to try this Effexor that's out. And so people would take it, and 9 times out of 10, they call me back or come back in and say, it's amazing, I'm all better. And why is the pain better without a pain pill? And why? Well, because I'm balancing your chemistry. That's why. So this was big, and most doctors, by the way, never caught on to this. During the 90s and even 30 years later, most doctors have never really picked up on the difference. The ones I use the most are Pristique is my favorite, Effexor, Cymbalta, and there's one called Fetzima, which we don't use a lot of. SSRIs are Prozac, Zoloft, Paxil, Lexapro, Celexa, Luvox, Vibrant, and the newest one is called Trintellix. And it's not that they're bad medications. They're good for certain people. SNRIs are more often better, but it really depends on the individual, their history, their symptoms. I would say probably average maybe 2/3 to 3/4 of the time, SNRIs are better than SSRIs. And again, to this day, most doctors think SSRIs are the be-all and the end-all. They never even delve into one of these because they just don't understand it. They never did understand it, and they still don't understand it. So that's just the reality of what we're dealing with. So then I started to see with some people, okay, that's better. My anxiety is better. My pain is better. But I'm tired. I'm depressed still. I lack motivation. I lack energy. So then I started really getting experience with Wellbutrin. So Wellbutrin's an DRI. So a little bit of norepinephrine, not a lot. It's not as much as the SNRIs. A little bit, but really the dopamine. So I started to see a balancing of dopamine and adding it to one of these two. And I call it the wow Wellbutrin: motivation, energy, depression going away. If sometimes people get sexual side effects from one of those two, it gets rid of those. Helps with weight loss. So it's amazing the results we see. It's usually better when I add it to. Now, if someone doesn't do well with either an SSRI or an SNRI, and neither of them, well, that means that, okay, probably serotonin and norepinephrine are not an issue. So now I look at dopamine and I look at GABA, and maybe Wellbutrin by itself, but most of the time Wellbutrin is better if I add it to something else. I call this the dynamic duo of medication would be like Pristiq, Wellbutrin, or Cymbalta, Wellbutrin, whatever. I call the dynamic duo because I put those together quite a bit. So then I started noticing what else? GABA. So then there was a medication called Topamax, you might have heard of the medication gabapentin. So what happens when you balance GABA? Anxiety goes away, pain gets better. So if there's any pain left over from an SNRI, then I add one of these, and the headaches go away. The pain of the body, the anxiety goes away. And they're very well-known medications. But Topamax is an amazing medication because not only does it do what the gabapentin does, but it actually also helps with weight loss. So there's all these new weight loss products out there, Ozempic and all these things. They're all the rave. But I've been using Topamax for years because it actually curbs the desire for sugars and carbohydrates. So I usually give it in the early evening, and it just knocks that out in the evening. The people eat better, they lose weight, they're happy. And it helps with sleep. It helps with a lot of things. And there's other things. So then I started really understanding bipolar disorder. So there's a whole different class of medications. You might have heard of things like Zyprexa, Abilify, Seroquel. The new ones you're going to see on TV, Vraylar, Rexulti, Caplyta. These are all we call the antipsychotic medications. Now, it doesn't mean that I give it for psychosis. That's not usually the case. It's typically for bipolar disorder. Now, these are actually called dopamine antagonists. What they do is actually slow down dopamine. So they kind of work on the dopamine side. So Wellbutrin speeds it up, and these would actually kind of slow it down. So sometimes we get like a good balance when I use one of those, which calms the brain down. So if the brain is really restless, racing, can't sleep because my mind is racing, it calms the brain down. But then if it makes them tired, I'll put some Wellbutrin in. So kind of a balance, I call it balancing dopamine 24/7 by something in the daytime and then something at nighttime. And it basically creates this nice balance in the system. Then we have Lamictal. Lamictal is the only antidepressant that works on GABA. So Lamictal is really good for persistent depression that's not getting better with other medications, or bipolar depression. And we have a new medication called Auvelity out, which is very exciting. So it works on dopamine and glutamate. So it really boosts. It's a very strong medication, but it really helps with. What's key to it is the glutamate. It's basically Wellbutrin with this other component that boosts glutamate. So it's really good for depression that's not getting better from other means like Wellbutrin or some of the other things we use. So that's kind of it in a nutshell. We got stimulants for ADD. So stimulants basically will come in and just kind of get everything moving better in this direction. And when you combine it with like a Wellbutrin or Pristiq, Cymbalta, whatever, so you have the combination of improving the flow this way, and then they can't crash backwards. So it's a nice, smooth transmission without this up and down and back and forth, because these other ones block that from happening. So when the stimulant works, it keeps working and doesn't crash. So that's when I put like an ADD medication into the mix. So that's kind of a conclusion. There's other things too, but that's pretty much the basics of medications. And I'll be going back to this when I'm talking to patients, and I'll kind of explain what the medications are doing. Anyway, but this is what's cool about it. When I said earlier about the fact that when I was into like chess when I was younger and loved the puzzles. Well, look at this. Isn't this like a fascinating puzzle here? And with me, I love like trying to figure out what's going on here and how can I solve the puzzle? How can I get the person better by figuring out what's going on? And that's the fascinating part of what I do, is learning how to figure out this and then it's a mixture of science, and it's fun. I mean, I think it's really fun to do this because it's fun to see the result. It's fun to figure out the medications when other doctors can't figure it out. I love challenging cases that other doctors have given up on, and I like to be challenged like that. So anyway, so we'll be going back to this. I mentioned my books also. My first 3 books that took me 12 years to finish. This is Healing the Mind and Body, the trilogy. It's a 3-book set. They sell on Amazon separately. But this was my first 3. This talks all about the science of everything. There's a lot of these diagrams in the book. There's a lot more detail. This is my newest one. This is a hardcover version of the Corona Protocol. I have a soft cover and also an ebook. But yeah, if you want to get the Corona Protocol, it's on Amazon, Barnes & Noble, and Walmart. And my first 3 books are on Amazon. So this book is basically 30 original short stories about people. So I really cover a lot of ground. Everything from depression, anxiety, ADD to homelessness and school shooters and narcissists and sociopaths. And so there's a lot of pretty heavy stuff in there. But I try to make it fun by telling fun stories about people, and so I've been getting really good reviews, so I highly recommend it. In the kids' case, the boy was a little bit more difficult. He had Fetal Alcohol Syndrome, which means his mom drank a lot during pregnancy, so he was very malnourished. He was basically like less than 10th percentile of growth. They have a lot of problems with school, with behavior, and both of them have a kind of a little bit of an autistic spectrum going on. So with him, it took Prestique Wellbutrin, and so he was first on Zoloft by another doctor. I put him on Prestique Wellbutrin. He was in much better mood. And then he's on a stimulant for his ADD. The secret with both of them was Abilify. So Abilify is a dopamine antagonist, again, a medication we call which is a mood stabilizer that basically calms down dopamine. So that calms down the brain, helps behaviorally. And then she's also on Vyvanse also, but with Abilify and a medication called clonidine. But basically, that's what's going on with them. And now, again, also, why does this happen? Why do these leaks happen in the system? There's 3 main reasons. The first reason is genetics. Like in the kids' family history, dad's in prison, mom died of suicide. So, I mean, that's pretty obvious that there's family history in that there. And then the kids grew up in an abusive environment. So that's, the 2 kids, the older kids that we didn't talk about, were so bad off that they were just unmanageable that they had to leave, that they had to be taken from the home, and a sad situation, but it was just kind of almost too late. They were too old and they'd experienced so much that it was a very sad situation. So genetics, but and genetics for anyone who has these, we got to ask about mom and dad. Well, yeah, mom was kind of anxious, dad was a drinker or whatever. Mom was a nervous lady. So sometimes you get an easy, like, oh yeah, anxiety, depression, but sometimes it's not easy because some people don't, in past generations, you don't say, oh, I'm anxious or I'm depressed. So you kind of know by people's lives, they were dysfunctional. Alcoholism was basically the addiction in the past, mostly smoking. Hormone changes. So the other key thing is times of change hormonally, which is puberty, which is a big one. That's why middle school and elementary school is a very common time this stuff happens. premenstrual for women, postpartum for women, and then for women, mid-late 30s, 40s, 50s, 60s. Now for men, you got puberty, because we don't have as many times of hormonal change as women do. So you got puberty, which is a big one, and then midlife. I call menopause. So menopause is basically men going through midlife crisis, and then that affects their mood, and then the third factor is stressors. So if you're exposed to a lot of situational stressors, trauma, things like that. So trauma and stress, like PTSD, being exposed to just extreme harm, and so that also situational stressors. So those are the main three things. But number one is genetics, number two hormones, number three stress. So those are what causes these things to happen. So when this happens, people can't help it. You can't help when you have these imbalances. It's just a matter of then coming to grips with it and say, okay, I can either treat it or not treat it. And most people don't treat it, by the way. They just go through life thinking that's just the way life is. But if you understand that there's an answer here, there's a chemical reason why this is happening, and there's medications are not a Band-Aid, they're not a crutch. They fix the problem, and if you get to the root of the problem and fix it, amazing how much better life gets. The following interviews are patients of mine who didn't want to be identified, and so I'm going to be speaking with them over speakerphone. And we're going to be speaking about a variety of topics. So I hope you enjoy it. So what's going on?
So I have a friend of mine who is also taking the Wellbutrin like I'm taking.
Mm-hmm.
And she's also, she had an Adderall, and then she also had a dextro amphetamine.
Okay.
I tried both different days. They both seemed to really work for me. Much more focused. Actually got a lot done, which was nice. So I just wanted to check with you, see which one might be better for me with the Wellbutrin, to hopefully get started pretty soon and get going on this.
So what? So I know you've been on the Wellbutrin by itself, right?
Right, I've been on a 450, 150, and a 300. So
450, right, the highest dose. What did the Adderall and dextroamphetamine? What did they describe? What you felt when you took them?
I felt just much more focused. I could finish whatever project I was on from start to finish. Wellbutrin helped out a little bit with that. This was much more, and I went just purely focused on what task I had at hand and finish it. And that just felt really good. They both, like I said, they both were pretty good. They both kind of did the same thing. Like I said, I did them different days, few days apart. But they both seemed to work, and that was my, just that focus and that kind of drive that I had it felt really good.
What was the kind of dosing on the Adderall? What kind of dosing?
So she had, I think she had 30 milligrams, and she cut it in half. So. Okay, so a tablet then. There's either 15 or I'm sorry, either 30 or 20, and she cut it in half. So. Okay. I think they might have been 20s, and then I took a half early, okay, and then I took a half later on both of them. So
when you said later, when did you take the second time?
I took about 8, 9 in the morning, and then I did about 2, 3 in the afternoon. Okay. So kind of stretched it out throughout the day.
And no side effects?
No, none at all. I felt great.
All right. Let me have you. I'm going to schedule an appointment for you so we can talk about this in more detail. So I'm going to talk to Leslie about getting you an appointment. But it sounds like you have an underlying ADD component. So it didn't cause insomnia. Didn't cause any other problems.
No, not at all.
Okay.
Like I said, I felt great.
Okay.
I was able to go to sleep. What would be the difference between the two? I guess we can go over that when we meet. But is there a big difference between them? Because it didn't feel like there was really.
There's not a big difference. I mean, dextroamphetamine is one component of Adderall. They're both good. It's just a matter of which is better. I mean, probably the more commonly used is Adderall. But we'll talk about, when we talk, I want if you can make sure and let me know the exact dosing and how much exactly it took. So if you can find that out, so we know the numbers too. Okay. All right. I appreciate you talking to me. Okay. I'll talk soon.
All right. Have a good day.
All right. So in his case, actually, we haven't really talked about ADD yet. So basically, he's on Wellbutrin. So he's on the combination of, he's on Wellbutrin only, really. So what that does is, so we got, basically it's a little bit of norepinephrine, more on dopamine. So it basically gets those chemicals moving, but it gets them moving because it prevents them from going backwards. So that's what makes them, it forces them to go forward. Now we take Adderall, and what that does is it comes in here and it really gets things going. It really gets things connecting better, more quickly. So it's got a kind of the combination of getting them moving, but then the Wellbutrin prevents the crashing, and that we also see that with like Proustic Cymbalta with Adderall too. That it's smooth, it makes it much smoother when you have something that prevents them from going back and crashing. So that's why. So again, it sounds like I'll probably put him on it. So he found out basically by. Not the most advisable thing to do is by taking other people's medications, but he did it, and so I'll talk to him about that more later. And this woman, I've been seeing her for many years. Just a regular check-in with her. She's been on the same combination of Cymbalta and Wellbutrin. Again, so for her, it would be serotonin, norepinephrine, and dopamine, those three. And she's been doing well for a while with that. So let me check in with her. Hello.
Hello, how are you?
Good, how are you doing?
Good.
Good. So tell me what the update is.
So as far as the prescription, right?
Yeah, are they still working well?
It is working well. I feel pretty good on it, and I was wondering though if there's any possibility that I could start going off of it.
Okay. How many? Let's see. You've been on for a number of years now, right?
Yeah, a long time.
Have you ever missed a day or two? Has that ever happened?
Yes.
What happens when you miss a day or two?
Other than kind of the side effects of it not feeling well, but going off of it just cold turkey doesn't work. Okay. Not good.
Remind me about your family history, mom, dad, who has any history of depression, anxiety, things like that?
It's on both sides for sure. Mm-hmm. With my mom's side, a lot of anxiety. My dad's side, probably some depression and anxiety. Mm-hmm. And so I've battled with this probably my whole life. So starting the medication later in life, it was very beneficial. But I'm just wondering now if I just feel like I worry, if I can't get to it or I can't get my prescription, I would really feel nervous not being able to have it. So that's mainly the reason why I want to go on with it.
It's a common concern. I think, number one, because people think, what if it becomes not available? Well, it'll always be available. The pharmacies always have it. And then people say, what if I can't get to the pharmacy? Or what if something, that's one thing I hear a lot. The other is that, I miss one day and I feel terrible, and I must be addicted to them because I can't stop them.
Right.
It's not addiction. It's kind of like a diabetic stopping insulin for a day, and you would think, what's the big deal? Well, blood sugar shoots through the roof and they feel terrible, and that's just one day missing insulin. These are kind of like that. I think the hint of knowing with you whether you're ready is that missing that day. If you miss a day or two and you really didn't notice that much of a difference, that might mean it's time to start this to go down slightly and start to do a slow process. The reasons to not stop them would be two main reasons. Number one, the length that this has been going on. So if this has been going on for most of your life, or starting, let's say, in the teen or teenage years, which is common, and strong family history. And so those two things right there mean that most likely you're going to benefit from staying on them. But again, I look at it this way. If you had diabetes, if you had blood pressure, cholesterol, thyroid, you would take things without even worrying about it too much but people think, well, that's different because that's a real medical problem because I can do blood tests for that. I can check blood pressure. It doesn't seem as real with these because you can't measure these. You can't do blood tests. And some people say, well, how do you know? Well, you don't know. And as far as the question, how long is long enough, it's a question that's very difficult for me to answer. If someone has a brief onset, let's say situational stressor happened, no history in the past, not a very strong family history, and just a trauma happens, they go through a difficult time and they go on to do better. These are people that might 6 months to a year later go off of it and be okay because it was just a stressor that set things off. And the third factor after genetics and hormones is stressful situations. And that's the people that might be on them for a shorter period of time. So in your case, you probably aren't going to like the answer, but the answer is probably just stay on and don't worry about it. And as far as not, you want to always have them around you. So that's why so you could have some people have some in the purse, some in the home. So that way, if you're out and forget, you can take it. And so
that's a good point. Yeah, I know. I think that's what it is. It's just, that's my main concern is just thinking that I can't get to it or I might travel somewhere and not have it. And because I know that I like how I feel on Prosteak, I really do. And it makes me feel just level and normal, that I can handle everything. And I remember how I was before I was on it, and it kind of scares me to think of going back to myself back then. So I guess that sort of answers my question.
Well, this is I call the new you. The new you is you on these. This is totally the person you're meant to be. Were it not for these factors that led to this, so that's how I look at it. So it's just balancing three chemicals in your system. That's all it's doing. And as far as the traveling thing, if you forget and you go on vacation and you forget, I can call them in wherever. I mean, as long as it's not out of the country. So I sometimes I'll do a call. I get a distress call from Hawaii and then I just called some into Hawaii or whatever. But the thing is, if you're going to travel, obviously these have to be a high priority. Remember to pack them, of course. And as far as being at home, because I know you live, I know what state you live in, and you should have just like I said, if you're worried about leaving him, missing it in the morning, just have some in your car or in your purse.
That's what I need to do.
Yeah.
Always, I have them in my pill tray, but then I need the bottle, probably just keeping little thing moments in there. Yeah.
Right.
Good point.
Good. Yeah, but the best thing to do is there's two ways of looking at it. One is to look positively, like thank goodness these are around for me to feel this way because my ancestors did not have the luxury of feeling this.
I know. Yeah.
The negative.
They would dull themselves with other things,
right,
that aren't as healthy, aren't as balanced.
Exactly. They would self-medicate. They just led miserable lives, and they had no solution, and that's just the way it was back when. Yeah. The other. Yeah. And the negative way of looking at it is, I have to take these stupid medications, and how long do I have to take these things? Well, there's only two things. They're not stupid medications. Is to be grateful for the fact that for modern science and the fact that, and like I said, I said Cymbalta, but you're actually on Prosteak and Wellbutrin. I call the dynamic duo my favorite combination. It's the best. You're on the number one combination I like to put people on. So, I mean, they're all good. Cymbalta's good. Effexor's good. They're all good. But yeah. Good. And I know you have some stress with your husband. I know he had to go to a boarding care facility, right? And, Yeah.
I mean, there's definitely, I wouldn't say there's a lack of stress in my life. So I don't know. Yeah. I guess, I definitely still have circumstances where it benefits me greatly.
Yeah, they just, and if anything, they help you to handle stress better is what it comes down to. Yeah.
Yeah.
All right, good. Yeah, and so any questions, let me know. I think if you're good, like I said, we'll just follow up later, but I think you're good to go. All right?
Okay.
I appreciate you coming on.
Thank you.
Thank you. Yeah, so in her case, again, serotonin, norepinephrine, dopamine. So she's got a combination of those three. She doesn't have the GABA at all, but she has, these three. So that combination of, those two medications balances those three chemicals, and that's extremely common. So probably the most common that I see in my practice is that combination right there.